Thank you, Irene. Thank you so much for the introduction, and thank you, everybody, for being here. It's my honor, and it's a great pleasure to be here and be part of this incredible group of neurologists and be part of this family, the family of patients fighting Parkinson's disease here at the University of Florida. As Irene was saying, I'm a neurologist, and I specialize in movement disorders. And I have an interest in new therapies for Parkinson's disease. So I'm hopeful that over the next 20 minutes or maybe half an hour, I can give you a brief overview about some of what we call the surgical treatments of Parkinson's disease, or more appropriately, maybe the advanced therapies for Parkinson's disease. Let me see if this is working. Great. Well, before we start, let me just ask a few questions. Dr. Spears was asking about how many of people in attendance have Parkinson's disease or a family member that, of patients with Parkinson's disease. But do me a favor, would you mind raising your hand if you have had deep brain stimulation surgery? Okay, a few people here. Good. Anybody here that has had therapy with duopa or the intestinal gel? 1, 2, 3, perfect. Excellent. Okay, so there's a few people here that have had some of these therapies. As you know, Parkinson's disease is a common neurodegenerative condition that affects many people in the United States and throughout the world. It's probably the second most common condition after Alzheimer's disease. And we know that most of the cases of Parkinson's disease are what we call sporadic. They occur without a strong family history. There is a small group of patients that may have a genetic mutation, but this is rare. And Parkinson's is characterized by a variety of symptoms. I think that most people, we know that tremor is part of the disease, but we know that what defines Parkinson's disease is a sense of slowness, is stiffness in your muscles, abnormal postures, difficulties with gait and balance, and in a proportion of patients, problems with tremor. We just hear all these really great talk about some of the non-motor symptoms of Parkinson's disease, as we recognize more and more that Parkinson's is not a disease that only affects the mobility. We know that Parkinson's disease has implications in other functions of the brain, and symptoms like constipation, difficulty with sense of smell, low blood pressure, problems with bladder, problems with depression and anxiety are also part of the disease and very common. We still don't have a cure for Parkinson's disease, but it's an active area of research as right now we have a variety of treatments that can help with the symptoms of Parkinson's disease, and those are the advanced treatments that I'm going to concentrate on to try to find better ways to treat the symptoms, particularly the motor symptoms of Parkinson's disease. Before I start, we know that over time, once you take your medications, most patients after 5 or 10 years tend to develop what we call motor complications. The effectiveness of the medications changes over time. The medications that initially were very helpful to control tremor, to control balance problems, to help with mobility and stiffness, over time the effectiveness diminishes. And what happens very commonly is that the duration of the effect doesn't last until the next dose. So you take your medications at 8, your next dose is around noon, but by 11 a.m., your symptoms are back. So there was a gap between the effectiveness of the medication to the next dose, what we commonly call the wearing off effect. The being off, when you talk to your doctor, being off means that those are the times when you have poor motor control, when your symptoms are not adequately treated. We refer to be on when the medications are working properly. And what happens over time, particularly as the disease continues to progress, the response to medications becomes less and less predictable, and patients start experiencing a variety of problems, including you take your pills and they don't kick in right away. It usually takes 20 minutes, 30 minutes for the medications to work, but then at times you take your pills and it may take up to an hour before you feel that the medications are working. Sometimes you take your pills and they don't work at all until the next dose, and you spend that period of time with difficulties with mobility. Sometimes you take your pills, they start working, but when they're working at their best, you develop these abnormal, fidgety, restless movements, what we refer and we call as dyskinesias. Fidgety, grimacing movements of the face, swaying back and forth of your trunk. And then as the medications start to wear off, those movements go away, but then the slowness of movement comes back. So over time, what happens is that the medical treatments are associated with these ups and down, these roller coaster during the day of effectiveness of the medications and lack of effectiveness of the medications. And when that happens, we have a variety of interventions that can be useful. We do know that there has been extensive research showing that when medical treatment has been maximized, the more advanced therapies can provide a much better treatment that medication changes. So at that point in the disease, when the symptoms of Parkinson's disease are not properly treated with medications adjustments, or if these problems with mobility are a significant problem throughout the day, that's when it's time to start thinking about some of these more advanced therapies. So just like the slide says, okay, I'm thinking I could be a candidate for Parkinson's surgery. Where should I start? Well, surgery for Parkinson's disease has been around for quite some time. So people have been operating on the brain since the early 1930s, trying to figure it out. At the time, we really didn't know much about the brain, and most of the surgeries were based on really basic knowledge of how the brain functions. But in the 1950s, 1960s, there were better ways to target deeper parts of the brain. And we started to understand the importance of some structures deep in the brain when it comes down to movement. So before we had Levodopa, this magical drug that has helped so many millions of people with Parkinson's disease, one of the main treatments was surgery. And in the 1960s, it was very common to have surgery for tremor, for if you have Parkinson's disease. And it was somewhat at the time, because we didn't know much about the brain function. What happened is that by chance, some surgeons found out that certain areas of the brain, if you would make a hole, you can actually suppress the tremor in Parkinson's disease. And then over years, that technique became better and better. And people discovered that if we make a small lesion in this part of the brain called the globus pallidus, primarily, or in the thalamus, another part of the brain very effective to control tremor, that the symptoms would be better. As Levodopa became available and people started using medications, the need for surgery was diminished because surgery was associated with significant side effects. Anesthesia was not as good, the surgical techniques were not as good, so there was a significant risk of having complications if you had surgery at that time. But then after Levodopa became available, people were doing really great with medication. But the problem that I just mentioned, this problem with the motor complications, the ups and downs after you have been taking Levodopa for a few years, now those symptoms became the challenge. And in the early 90s, people started looking at surgery as another potential treatment for these ups and downs. And one of the ways that they started learning how to do this surgery properly. The surgeons, if they place the hole in the brain in a location that was not perfect, it will cause some problems, as you can imagine. You needed to be really good at placing placing the hole exactly where you want it. To test that, when people were in the operating room, these surgeons everywhere, but there was this surgeon in France that was using electrical stimulation. He was, before, to confirm the location of the lead to make the hole, he was using high-frequency stimulation to make sure that it was the right spot. Because if he was off, he will get side effects, and if he was in the right location, then he will get the benefit. So he realized that, okay, maybe I don't have to make a hole. Maybe instead, what I can do is just keep that chronic stimulation and continuously deliver electricity to the brain, and I can get the same symptoms. And that's how deep brain stimulation was created. Then what we call the the pacemaker of the brain was based on that idea that instead of making a hole, maybe we can change the way that the brain works if we deliver high-frequency stimulation. So deep brain stimulation, it's a surgical therapy that involves the implantation of stimulating electrodes into different parts of the brain. We think that like an electrical wiring in an appliance, if one or more of those circuits is not working, then the machine is not working properly. And interrupting these abnormal signals may improve the symptoms of Parkinson's disease. A very common question coming from everybody in the community and patients is like, so how does it work? And the honest answer is that we don't know. We don't know exactly how deep brain stimulation works. We have a lot of ideas. There's plenty of hypotheses trying to explain the benefit of deep brain stimulation. But we think that what happens is that when you have Parkinson's and you don't have enough dopamine, the way that certain cells in our brain work, they are always firing at a specific frequency. And we know that that's important for the brain to work properly. When you have dopamine loss, like in Parkinson's disease, that frequency is off, and the brain is firing at an abnormal rhythm. What happens is if you put a lead deep into the brain and you deliver electricity, the electricity may create a signal, like a white noise signal, that's going to block that abnormal firing pattern, allowing the brain to reestablish the normal function. And that's how we think that DBS works. The biggest advantage of DBS over the old surgery was that if you were trying to make a lesion in the brain and you would make a hole that was too big, you would get some benefit, but you would also get some side effects. And once you make a hole in the brain, you can't go back. So people were left with significant side effects from surgery. And this was particularly troublesome when you had surgery in both sides of your brain. The biggest advantage of DBS over surgery is that with technology, we could change the electrical field, and we can decide the amount of electricity that we will be delivering to the brain, making a bigger area of stimulation or a smaller area. So the side effects and the benefit that we would get with the therapy could be modulated. We could actually change the amount of electricity delivered, and we can correct for side effects. This reversibility of DBS is one of the biggest attributes compared to surgery. DBS is an elective surgery that could be used as a treatment. DBS is not for all patients with Parkinson's disease, and this is really important to emphasize. Only about 30% of patients with Parkinson's disease are good candidates for this surgery. Why is that? It is critical to be successful with this kind of intervention to select the most appropriate candidates. And DBS only allows you to treat certain group of symptoms in Parkinson's disease. DBS doesn't get you any better than how you look at your best with maximized levodopa. It just gives you more adequate benefit. And for that reason, if you have symptoms that are not symptoms that we can improve with deep brain stimulation, DBS may not be an option for you. And as you can imagine, anytime that you have brain surgery, you are committing yourself to a risky intervention. Deep brain stimulation is probably the safest surgery that is performed by neurosurgeons, but it also carries significant risks, like a risk of stroke or a risk of infection. More importantly, deep brain stimulation is not a cure. And as I mentioned before, this therapy is useful for the symptoms of Parkinson's disease. It doesn't change the disease progression. It helps to minimize the problems with quality of life related to some of the symptoms. And in the right patient, with the right team, it could be incredibly helpful. So how do we do deep brain stimulation? What are the steps entail in trying to figure out if I'm a good candidate? How is it done? Well, we're very fortunate to be in one of probably the largest center in the world performing deep brain stimulation. There are about 140 or 150,000 cases or patients being operated on around the world for the past 30 years with deep brain stimulation. And approximately 1 out of 100 patients have been operated here at the University of Florida. Dr. Kelly Foote and Dr. Mike Oken really account for 1 out of 100 patients in the entire world that have had deep brain stimulation. It's critical to have that experience because for deep brain stimulation, 1 or 2 millimeters difference in the brain can be a huge difference when it comes down to the effect on the symptoms. So what happens on the day of the surgery is that the neurosurgeon will administer local anesthesia and try to use a little frame that goes around the head to try to find the right spot, the right area. As I mentioned before, the way that we target these structures, we have known for many years that the area of the brain that is important for movement and it's causing some of the symptoms in Parkinson's, it's deep into the brain. So it's not on the surface of the brain. And for us to get there, what the surgeons, what the neurologists do, we create with MRIs and CAT scan, we create an image of those structures and we plan how to get there, passing a probe deep into the brain to deliver a contact and deliver what we call a DBS lead into that specific spot. And then what we do afterwards is that once we found the right area, then we attach that lead to a stimulator, to a pulse generator. It's a pacemaker, just like the cardiac pacemakers. And that, we connect the two with a extension wire, and we actually, in clinic, come and modify and make the adjustments needed to improve the symptoms, including tremor. We do the surgery when the patients are awake. The reason for that is that your neurons only fire when you are awake. Well, in general terms, they're always firing, but when you're awake, we can use the information of those neurons. As we pass a probe through the brain, we can identify specifically what group of neurons we identify those cells based on that pattern. Like neurons talk, they sing. And if we listen to the songs, we can identify what kind of neurons we are actually recording. And that's very useful information because when we want to put this lead exactly in the area that controls movement, being precise is critical. The area, just to give you an idea, the subthalamic nucleus, which is one of the targets that we use, is about the size of a pea. And from that structure, only a quarter is involved with movement. So we're really trying to put this probe in a very tiny spot. So a lot of the things that we do during surgery is to ensure that we are as precise as we can, and 1 millimeter can make a big difference. So when we have the patient awake, and as we're passing that probe, we can also test the effect of electricity, which is also really important. So not only being awake during surgery allow us to identify the neurons, but it also give us the opportunity to test and see what kind of side effects you get. Because let's say that we test the electricity and you're getting muscle spasms, or your face is pulling to one side, or you can't talk. That means that we're not in the right spot, and that's the perfect opportunity to really make a change. Then after, I think I mentioned this, after we precisely localize the area, or the target for the permanent DBS lead, we attach that to an external generator, and then you can come to our clinic and make all the adjustments necessary. And we commonly refer to this therapy as a surgical therapy for Parkinson's disease, but it's not a surgical therapy. The treatment is not the surgery. The treatment is the electricity. So that's why, right after the surgery, when we use the surgery to put the probe in the brain into the right spot, and we attach it to the generator. But what really makes the difference over time is the amount of electricity. So it takes time to find out that perfect setting and adjust your medications in combination with adjustments to the pacemaker to really maximize the treatment of the symptoms. So Not uncommonly, you have surgery and you haven't seen an aunt that just happens, that came to town to visit, and she says, wow, I heard you have the Parkinson's surgery, but you look exactly the same to me. Well, the reason for that is that it takes time. Surgery is not the treatment. Electricity is the treatment. So it takes a few months to find the right amount of electricity to control the symptoms. The programming, as I said, we do it as an outpatient. You come to our clinic, we make some changes, and we do it little by little until we figure out what are your needs. Every patient with Parkinson's disease has different needs. So we need to be familiar with what you're trying to accomplish. We need to be familiar with your specific symptoms, and then we have to create a plan to how to get those symptoms better. So that takes a little bit of time. The technology available has changed dramatically over the past decade. When the surgeries became available in the early 2000s, there was one system and one or two probes. And now, over the past year, we have 3 different systems that are, well, 2 that are approved, 1 that is probably going to be approved very soon. There's another company that is also trying to create a new system, and that has led to new innovations and new technologies trying to maximize the potential benefits from this therapy. We get newer leads, better ways to deliver electricity, longer batteries, better programming tools, new ways to find the right spot in the brain. So there's a variety of innovation that it's coming that is going to help us and is going to help our patients to get the best out of these therapies. Let me show you a quick video because I wanted to give you a really broad overview about how the surgery is done. And now let me show you a video. This video is actually taken from the internet. Dr. Sanjay Gupta was here at the center not that long ago. He was doing a little documentary about how things are done at the University of Florida, and it goes through the different steps of the surgery. So I think it will be so much better for you to see it in real time, how the surgery is performed.
They specialize in a treatment called DBS, deep brain stimulation. It uses electricity to relieve their patients from the debilitating effects of movement disorders. Through their quest to fix the brain, they are discovering new ways to control the brain, or DBS.
It's honestly a typical Wednesday for us, which is 3 deep brain stimulation lead implantations.
Wow. Hello again. What an audience here.
When we go into the
for a second. So when I was mentioning that the way that we try to target this very tiny structure in the brains is using a mathematical model using 3 different dimensions. And the way that we do that is using that frame. You see that metal frame around the head. We use that because once we attach that to the patient's skull, you can see we do it with a local anesthetic, and we have a couple of pins that are attached to the skull very firmly, and then the frame allows us to get a CAT scan and using an MRI create a mathematical model or exactly how to get to different parts of the brain. It is so precise that the error of doing that mathematical equation using that frame could be in the margin of less than a millimeter or half a millimeter.
When we go into the operating room, I often say it's a bunch of cool cats in that operating room. That is not a typical operating room.
You feel all right? Lean your head back. Let me hold your head. Just relax your head. It's not painful, but it's stressful. And a lot of what we do that may seem a little weird to see in an operating room is really designed to alleviate that stress. Hey, Fortress.
So this is how the typical patient or the typical operating room looks on a Wednesday or on a Thursday with Dr. Foot. After the frame is placed, we comfortably position the patient in the room, and then you can see there's an X-ray machine that will allow us to take X-rays and to confirm once you pass the leads that nothing is moved. And then you can also see there's a black attachment. Let me see, I have a laser here. Yeah, this is part of the frame that's attached to a little device that allows us to very slowly pass the probe slowly through the brain until we find the right spot. Everything has to be done with no contamination. The patient is awake because after you put some anesthesia on the skull, or on the skin and the scalp, the skull itself doesn't have pain receptors, so you can actually make a tiny hole of the size of a nickel, and that's all you need to pass these probes and make the adjustments.
A fortress steep and mighty. There's a vessel, right? We focus on the music to try to take their focus off the fact that I'm drilling a hole in their head and cutting their scalp. Okay.
Can you snap your fingers?
That was pretty good.
Their first patient today is suffering from Parkinson's disease.
She has tremor and this drug-induced extra movement called dyskinesia and motor fluctuations, and it affects mostly her left side.
One of the things that may surprise you about deep brain stimulation surgery is that the patient remains awake.
Because the way
It's really important, and as you can see now, you see Dr. Ockham, you see Dr. Almeida doing different testing on the patient. And that's the importance of having the patient awake, that we can map the brain, we can listen to the neurons, but we can also do some testing looking for improvement in the symptoms and looking for side effects. So part of the surgery, patients typically worry about, like, do I need to be awake during the whole procedure? What I'm supposed to do? You basically, these kind of movements, moving your arms, lifting your leg, those are the things that patients are required to do during surgery. And as you can see, there's no blood, there's none of it. It's a very small incision on the back. And it's important for us to be able to talk to the patient so we can fine-tune and precisely find the area that's going to help with the symptoms.
The patient remains awake.
Because the way sedatives work is by suppressing brain activity, right? So we'll get better recording if we don't use any sedatives.
And then
Doctors Okun and Foote mainly focus on movement disorders. That's where functional regions of the brain have stopped working due to cross signals or irregular activity. The brain is often described as an incredible interconnected circuit, and the delivery of electricity is at the root of what makes DBS work. By introducing electrical impulses to circuits in the brain associated with specific motor skills, the doctors believe they are helping reroute or possibly replace the rhythmic connections between neurons. The doctors admit they are not entirely sure why DBS works, but they do know how it works, and that the exact placement of the electrical leads is the key to a successful implant.
And we learned that these operations are really specific. And if you miss by a millimeter or two, it's like the difference between, ending up in Florida or ending up in Australia. It's a big deal. In the next couple of millimeters, might start to see a transition. So what we then do is we put a tiny little lead into the brain called a microelectrode. And we listen to the cells, and they sing a song. And the song that they sing allows us to tell where they are. And so as you get to different areas, it's like driving through Europe. As you pass through different countries or different borders, the language changes.
That's great. So you can also see the MRIs. So we start looking at the MRI to determine the anatomy, determine the area that we're going to try to target, and then there's all these different steps that we use to fine-tune the precise location. Now, who are good DBS candidates? This is a pretty general overview about who would be a good candidate. The most important step before considering these kind of surgeries is having a multidisciplinary team that's going to assess your disease, your individual symptoms. What symptoms do you have? What are the things that are affecting your everyday life to see if you're a good candidate or not? But in general, people with Parkinson's disease that have moderate to advanced disease, DBS is very good at helping with the ups and downs related to the motor complications and the medication side effects. If you have a lot of wearing off, if your medications are not working consistently, if you have a severe and unpredictable pattern of response to Levodopa, DBS may be quite useful. DBS is not going to help with your memory. It's not going to help with your speech. It's not going to help with your depression. It's not going to help with anxiety. There's a variety of things that DBS is not going to help you with. And as a matter of fact, it may actually make certain things worse. But the things that DBS is very good at is these ups and downs related to these motor symptoms. You need to have a good response to levodopa, even if it's brief. As I said before, DBS can get you more benefit, constant benefit, because as opposed to the medications, DBS works 24 hours a day. We're always delivering electricity. Having good on-period function, even if it's brief. I talked to you briefly about the troublesome movements. You have failed multiple medications, what we discuss as unsatisfactory or refractory medical symptoms, and this is important. It's critical that you are managed and seen by somebody that has experience treating Parkinson's disease, like a movement disorder doctor. Realistic expectations is also important. Unfortunately, as I said before, DBS is not a cure, and it doesn't help with all the symptoms. So having set goals of what are we trying to accomplish with this elective surgery, it's really, really important. So most patients have everybody has different expectations, different goals, and discussing these goals with your doctors is really, really important before you go through the surgery itself. People that have an adequate medical risk, obviously, if you have a variety of other medical comorbidities, then that can preclude surgery, that will disqualify patients for deep brain stimulation, and it's also important to have an adequate social support. The biggest risk of surgery is the risk of intracranial hemorrhage or the risk of stroke, that it's about usually 1 to 2%. So it's a very small risk, but it's a real risk. And that's why making the decision of having this kind of intervention needs to be a team effort, a team of not only your doctor, your family, your significant other, but other providers like psychologists, neuropsychiatrists, and the surgeons. There is a risk of infection as well, although rare, but as you can imagine, every time you cut the skin, there's a risk of infection that's around 4%. And every time you have a mechanical device in your body, there's a risk that the device may not work or may fail. So you may need replacements of the connections, the batteries, and the surgery, the probe itself. So I have a few minutes, so I want to move on to some of the other therapies. So who are not good DBS candidates? If you have Parkinson's disease with severe cognitive impairment, the potential benefit with DBS would be limited, because DBS is not going to help with that component of the disease. It can actually make the symptoms worse, and when you have severe cognitive problems, the leading source of disability are other things, are balance, cognition, memory, and improving your tremor may not give you an improvement in quality of life. Lack of response to levodopa, or people that have atypical Parkinson's disease, atypical Parkinsonism, are not good candidates for this therapy. Severe imbalance and posture instability that speaks of advanced disease and symptoms that are not responsive to levodopa. We typically say that if your symptoms respond to levodopa, there's a good chance that DBS is going to help you with that symptom. So if you're having symptoms that are not managed with dopamine properly, then DBS is not a good option. People that have unstable psychiatric symptoms certainly are not good candidates for the surgery. Let me move on to some of the other therapies. I know that we're getting close to lunch and everybody's hungry, so I don't want to keep you here too long. But over the past 2 years, a new therapy for advanced treatment of Parkinson's disease became available in the US. This is not a new therapy. And again, it's not a surgical therapy. We use a surgery to place a tube into the stomach and the small bowel, but the therapy is levodopa. What is new about this therapy is the way to deliver levodopa. One of the reasons why people with Parkinson's disease have these ups and downs as the disease progresses is that the use of levodopa in the stomach becomes more and more erratic. The number of dopamine cells also change over time, and the way that they use medications becomes more and more troublesome. There's a variety of factors that affect the absorption of levodopa as the disease progresses. Slow emptying of the stomach is a common problem. Interference of your medications with protein. All these factors affect the response to levodopa as time goes by. So one way to bypass some of those problems is delivering levodopa directly into the small intestine. There's a small portion of the small intestine where levodopa is absorbed. And if you can put a tube that goes right there, and you're delivering small amounts of levodopa constantly instead of taking a pill, but just delivering every 5, 10, 20 minutes, you may be able to smooth out the ups and downs that come with medication. That was the whole idea behind this concept. And this therapy has been available in Europe for about 10 years or so. How is it done? Well, the drug is levodopa. It's just that it comes, instead of coming on a pill, comes in a liquid form. So that liquid form is attached to this tiny pump that you see over here. I have better pictures, actually. And that pump is going to infuse the medication directly into the small bowel. So this requires to have a surgery. It requires that you have a tube that goes into the stomach, and inside that tube, there's another little wire, another little tubing that goes into the small bowel. So this is not done with general anesthesia. This is done by the GI doctors the same way that you would get an endoscopy, like upper endoscopy. They can place this tube that comes then through the stomach, and as you can see, has an extension. That little extension tubing has 2 ports. And one of the ports, it's attached to the pump. You can see here the patient is carrying the pump in a little pocket here, but the pump looks just like this. And what happens is that in the mornings when you wake up, you get a cassette that has the liquid levodopa, you attach it to the pump, you then attach the pump to the connector, and you press run. You turn on the pump and let the pump do its thing, and then just slowly deliver medications throughout the day. You can use this pump for about 16 hours during the wake hours. You cannot use it at night because of a variety of things. But during the day also has the advantage that if your symptoms are suddenly worse because you ate something or because it was a stressful day, there's a button that can deliver extra doses of levodopa every 2 hours. In the mornings, you have to use these cassettes, and then depending on how much levodopa you use, you may need more than one. You have to be careful to avoid problems with the tubing. The most common complication of this system is problems with the tube, as you can imagine. So complications are common, particularly during the first year. So the tube getting clogged, breaking down of the tube, dislocation or fracture of the tubing, it's not that uncommon, particularly within the first year. Some of that may have to do with the fact that once you become familiar with the tubing, it becomes easier to do it. Once you get into a rhythm, once you figured out the system, how to do it properly, there's a better care of that tubing. It does require some maintenance. You have to flush the tube every day, because if you don't and you leave the levodopa in there, it's going to become really hard as cement. So then the tube is clogged, and then you need a new one. How do you get a new one? Well, you have to go and see the GI doctor, and then they have to pull one out and then just put a new one. So as you can imagine, it requires more. It definitely requires more maintenance. You should be able to wear the machine with you wherever you go. You can stop it briefly, like if, let's say, you're going to take a shower or if you're going to go swimming. Once you are done, you can actually cap the tubing. You need to flush it, and then you can restart the infusion. Using this infusion, it doesn't stop you from also taking medications. So sometimes you can use medications by mouth to try to maximize the symptoms. What we saw on this big clinical trial done here in the US was that patients have significant reduction of the off time, the time where mobility is not good, the time when you have poor motor function. There was a reduction of approximately 4 hours without increasing dyskinesias. And it kind of makes sense if you think about it, because now you have to take lower amounts of levodopa to control your symptoms, because it's going directly into the stomach and because small bowel, and because you're getting more of it constantly. So you can use lower doses of levodopa throughout the day and achieve a better, more continuous state. There are some complications with the tubing, as I mentioned, so sometimes infection can occur as well, abdominal discomfort, abdominal distension. The therapy can also at times cause problems with low blood pressure if you have a predisposition to have low blood pressure. And gastrointestinal complications are not uncommon. Particularly, you see in this graph showing that it's more common within the first few weeks. But then long term, once your body kind of gets used to it, those are less and less. So we talked about this. Some people there was a concern in some of these clinical trials that some people may have neuropathy. We're not sure why, so we typically monitor for that. It requires, the patients that may benefit from this are the patients that have these ups and downs, these fluctuations that may, that required more predictable response to levodopa. One of the other therapies that I wanted to mention today that is not available yet, it's only available in clinical trials here in the US, is this therapy called apomorphine infusion. This therapy is not new. It has been around in Europe for quite some time. And anybody here uses Apokyn for their Parkinson's, the injectable form of levodopa? No? There's one person there, perfect. So Apokyn is a very powerful dopamine drug. So we have it available in an injectable. So let's say that all of a sudden your Parkinson's symptoms come back, and then you are due for a dose of levodopa in an hour, but you can't move, you're really slow and you're really shaky. One way to kind of maximize or minimize those symptoms is using apomorphine, and you can inject yourself with a small needle, and then the effect of that drug, it's quick. It takes about 5 to 10 minutes to give you the benefit. But the problem with the drug is that it doesn't last too long. It gives you only about 30 minutes to an hour of benefit. So you can't just really go around injecting yourself every hour, right, to try to get the symptoms. So to bypass that problem, they created this pump, which is a small pump that looks more like a cell phone and that can deliver the drug little by little every hour, but using a subcutaneous injection. So you can put a small needle subcutaneously and attach that to this small pump, and the pump can deliver this medication. Apomorphine is a powerful drug to help with the symptoms of Parkinson's. It can cause a lot of nausea, so you need to take anti-nausea medications for months. And people that have trouble tolerating this group of drugs that we call dopamine agonists may not be the best candidates for this therapy because apomorphine works in a very similar way, like medications like Mirapex or Requip. So people that have side effects with those medications are likely to have side effects with apomorphine. And this therapy could be quite useful in the right patient if they can tolerate the therapy. It's a little less invasive because it doesn't require a tube in your stomach. It doesn't require brain surgery. It just requires the use of an injectable, of a small needle going into the subcutaneous tissue and attaching that to this machine. You can use it only during the day. The problem is that the drug has more side effects. This is not levodopa, and levodopa is probably the most powerful drug that we have with the best side effect profile. Apomorphine have other side effects that I just mentioned. The drug is not, this specific therapy is not available, it's still in clinical trials, but we're hopeful that it may become, in the future, an option for our patients, and for the right patient, may be a good option in patients that have the similar symptoms I described, these ups and downs, these motor complications. Once again, some of these therapies are directed to the problems with mobility, tremor, and wearing off in between the doses. There's no good data comparing these, all these therapies that I mentioned. You know, there's no good studies looking at what's best, DBS versus levodopa infusion versus apomorphine infusion. There's basically 2 small trials that look at this. Some of the recommendations are mainly expert opinions. What I would say is that the selection of all these therapies needs to be carefully determined by you and your doctors. There's no magic algorithm that's going to tell you, you are going to do good with this therapy versus this therapy. This is what you need to do. The way to get there is to discuss what your needs are with your patient. What kind of symptoms, what are the symptoms that are bothering you? How do you do with medications? What are the goals of therapy? And discuss the pros and cons, because as you get a sense, all these therapies has potential benefits, but they also come with some risks. So it's all about discussing this with your team and coming up to a decision of if you, first of all, are you a good candidate for this? And then which one of these therapies may be the most suitable for you? Well, I just finished at 12:30. We should have some lunch. I'll be happy to take questions maybe a little bit later. And I really appreciate your attention. Thank you so much.